Okay, and we're back. And so now we talked about the depressive episodes. Now let's talk about manic episodes. So when we talk about, okay, we're good. When we talk about manic episodes, what we're talking about is an elevated, expansive, or irritable mood for at least a week. Okay, so we talked about the depressive. That's on one end of the pole. So you have baseline, you go to the left, you have your depression. And then if you go to the right, you're going to have your mania. Now, at least 1 week with an abnormal and persistent increase in energy, activity, most of the day, all day, with at least 3 of the following symptoms. Now, I do have to say here that some people will think that mania mania feels really good. It's like euphoric, it feels awesome. That's not always the case at all. It's just an expansive mood. It can be elevated, but it's expansive. It's bigger than normal. That can mean that, yes, it is elevated, it's euphoric, but for other people, it's just irritation. It's irritation. It's as if everything is vibrating because everything is so elevated. And again, at least 1 week with at least 3 of the following symptoms: an inflated sense of self-esteem or grandiosity. So this can be like, I am the greatest thing. Somebody suddenly has a great big ego, overly confident to the point of braggadocious, grandiosity. Again, I am the most beautiful, the smartest, the most athletic person in the world. A decreased need for sleep. Sometimes you'll see individuals who are manic who don't sleep for days. 3 days, 4 days, 5 days, no sleep needed. Again, because there's so much stimulation in the brain. They're more talkative than usual. Again, you just have to take the baseline of the individual into consideration. If it's somebody who's already talkative, this doesn't count. It has to be more talkative than what they would normally do. And what happens sometimes is they're more talkative. And then when they're talking, their ideas are all over the place. They might go from this one idea of starting a new business, then all of a sudden they're talking about their kid. And then all of their sudden they're talking about squirrels. Then all of a sudden we're back over here talking about what's going on in town. It's all over the place. And then they're highly distracted. So again, they might be on one topic and then all of a sudden they're literally like the squirrel. And then there's something else. They're highly distracted. There's also increasing goal-directed activity. And this is sometimes what people are interested in, saying like, well, if I was manic, I'd get so much work done. Not necessarily. Not necessarily. In some cases, yes, some people are more creative and, can write books and do things like that when they're manic. But I wouldn't bank on it, because there's also cases in which there are individuals who, they again increase in goal-directed activity. Maybe they, are thinking like, oh, I'm going to start a DVD business. And so they go and, let's see here, buy a lot of different or broken DVDs at a pawn shop and take them home and take them all apart and try to fix them and put them back together. And then you just have a house full of broken DVD players. So it's just kind of a crapshoot. Also, excessive involvement in activities that have a high potential for negative consequences. So impulsivity goes through the roof. This could be things like driving too fast, drinking more than usual, using drugs that maybe they wouldn't otherwise use, having sex with multiple partners. Shoot, what was I going to say? Maxing out credit cards, going on a big shopping spree. That is the type of behavior you might commonly see. Okay. Also, okay, so we have those. Then there has to be impairment in functioning. And if somebody's experiencing those symptoms, they're probably going to have a hard time functioning, maintaining, social relationships, going to work, not getting in trouble. So you have to have that, or you have to be hospitalized. And we'll talk more about that in a few minutes. And the episode is not attributable to the effects of substance abuse or other medical conditions. So those symptoms we just talked about can be similar in some cases to the symptomatology of or the side effects of methamphetamine use. And so, depending upon what kind of population one is working with, you might have to basically try to suss out whether this is a manic episode or whether somebody might be using a drug like that. Because if they are, it does not qualify as a manic episode. Okay, so the main disorder that people are interested in here is bipolar 1 disorder. Again, we're looking at two different poles here. Oh, let's see if I can move this. I don't know if you guys can even see this or not, but okay, there, that's a little bit better. Now, the criteria for bipolar 1 manic episode. That's it. That's it. That is the diagnosis for bipolar 1. And what's interesting here is that you don't need you don't need to qualify for a major depressive episode, even if it's probably going to be present. But in order to garner a diagnosis for bipolar 1, you just need one manic episode. And so just to look here, okay, let's see if there's something here. Okay, just to look here. Okay, so euthymia, that's your baseline. And again, with mania, again, we're seeing that elevated, expansive mood. And then what we will commonly see is, again, the roller coaster all the way down into depression as well. And depending upon, this is a rapid cycle here, like directly all the way up into mania. There's no gap here. There's no remission, directly down into depression. And depending upon, again, somebody's bipolar disorder, that might look like that. There might be remission. Somebody might experience a manic disorder or manic episode, and then there's a little bit of a gap, another one, and they don't drop down into depression as much. It just varies. Now, what's also interesting here, and I'll go back up for a second, is that, and let me grab it just really quick here. For, sure, I'm on this one. It is important to note again that if there's a need for hospitalization and you have those symptoms, that in and of itself qualifies as the dysfunction. Maybe you haven't seen the social or occupational issues yet for dysfunction to get that diagnosis of the episode, but if there's a necessity for hospitalization, you've got it right there. So again, this is bipolar 1 disorder. And let me see, I'm pretty sure I've got some more aspects that I can go into. And when somebody is manic, it can be difficult because very commonly they won't know that they're manic. They won't think that they'll need treatment. It just, you might see, I mean, they might change their dress, be more sexually suggestive, flamboyant. They might, oh, gambling, I didn't mention that, antisocial types of behaviors, maybe hostile, physically threatening, again, kind of delusional, again, that enhanced sense of grandiosity. They, obviously there can be serious consequences in a manic episode as well. I mean, we'll talk about suicide here in a second. The prevalence rates, the 12-month prevalence rate. Okay, so the chances of somebody developing bipolar 1 disorder in the next 12 months in the US is 1.5%. And it's pretty much the same between men and women. So about 1 to 2 individuals out of 100 will be diagnosed with bipolar 1 disorder in the next year. And usually when people are most commonly going to be diagnosed with bipolar disorder is somewhere between 20 and 30 years of age. But it can, there can be an onset at any point in the life cycle. But the average age of onset is right around 22 years of age, 21 and a half for women, 23 for men, thus right around 22. Let me see here. Promise I'm still on this end. Okay, so when it comes to suicidal thoughts or behaviors, the lifetime risk of suicide for individuals with bipolar disorder is right around 20 to 30 fold. Again, with major depressive disorder, it's around 17 times. Here, we're talking 20 to 30 times greater than the general population. About 5 to 6% of individuals with bipolar disorder will die by suicide. So that's about 1 out of every 20 individuals with bipolar disorder will commit suicide. So with that being said, okay, so we have our manic episode, then we have a hypomanic episode, which is going to be associated with bipolar 2 disorder. Now, hypo means under. So this is going to be less severe. It's still serious, but it's less severe than a manic episode. And so you have to have, again, that elevated, expansive, irritable mood for at least 4 days with an abnormal and persistent increase in energy or activity most of the day, all day, with at least 3 of the following. So again, instead of a week and 5 symptoms, now we're down to 4 days and 3 symptoms. And you have those same symptoms. So again, it's just a lower level of mania. And you have to basically change in functioning that others notice. Again, it's not as excessive as the manic episode, but again, you're maybe more, egotistical. Maybe you're doing a couple of impulsive things. You're not sleeping as much, and other people are noticing. But it's not severe enough to cause dysfunction in social or occupational functioning, or you don't need hospitalization. Hospitalization, probably manic. And so you might be able to go to work, still do normal things, but again, outside, you're still behaving in an uncharacteristic way. And this part needs to be taken out. This third one needs to be taken out. Not applicable here. That's mania. And it's not attributable to the effects of substance abuse or another medical condition. So this is where bipolar 2 comes into play. Because again, it's still severe, but it's basically your less severe form of bipolar disorder. And you need at least, here's what's different about bipolar 2. Whereas with bipolar 1, all you need is a manic episode. That's it. With bipolar 2, you need a hypomanic episode and a major depressive episode, which is very different than your bipolar 1. And you can never have had a manic episode. You have a manic episode that bumps you right up to bipolar 1 disorder. So it has to be hypomanic, and you have to have that major depressive episode. And the hypomanic and major depressive episodes, they're not better explained by any other psychological disorder. So that has to be sussed out. And the depression and hypomania, they do cause clinically significant distress in certain areas of life. So it is getting in the way of somebody functioning. And so this is what it looks like in comparison to bipolar 1. Whereas bipolar 1, you were going all the way up to mania and then all the way back down to depression. Again, there was that big drop there. With bipolar 2, you've just got you have the hypomania, which again, not quite as severe as the mania, and then you have that major depression. So you can look at bipolar 2 as a less severe form of bipolar disorder, even though both are very concerning. Bipolar 2 is going to be a little less severe. And the prevalence rate of bipolar 2 disorder is right around 0.8%. So, and that's in the 12 months. So in the next 12 months, about 1 out of 100 people will develop bipolar 2 disorder. And this could be the prevalence might be a little bit higher in general. Depending upon the diagnostician, they might miss the hypomania, thus diagnosing the individual with major depressive disorder. Or this could be something in which not as many people report it because the symptoms are not as severe, even though that depression is there. And when it comes to suicidal thoughts or behaviors, about 1/3 of individuals with bipolar 2 disorder, they do report a lifetime history of suicide attempt. The risk of attempted suicide in bipolar 1 and 2 are pretty similar. There appears to be about equal rates of suicide and deaths across individuals with 2 and 1, although they're both significantly higher than the general population. And the time spent in a depressive episode is associated more significantly with the diagnosis of bipolar 1 or 2 in terms of suicide attempt risk. So that depression is highly involved with it. Okay, so with that being said, then we have cyclothymic disorder. This is going to be a chronic version of bipolar disorder. So again, it's like persistent depressive disorder, but for bipolar disorder. And this is where an individual alternates between periods of mild depressive symptoms and mild hypomanic symptoms. Again, persistent depressive disorder. You have those mild depressive symptoms over an extended period of time. But the episodes, they don't meet the full criteria for either the full major depressive episode, which would get them a major depressive disorder diagnosis, or a full hypomanic episode or manic episode, thus throwing bipolar out the window as well. But again, they have traits. There are traits. So when somebody has traits of a disorder, again, you can say they have traits of this disorder or that disorder, but they don't have the full-blown disorder. They don't meet enough diagnostic criteria, but there are still symptoms related to it. And these hypomanic or depressive mood states, they can persist for long periods of time. And it has to last for at least 2 years. So at least 2 years, there have been numerous periods with hypomanic symptoms, but they don't reach the criteria for hypomania, and same for depression, but they don't reach that episodic level. And the symptoms have been present for at least half the time, and the individual has not been without symptoms for more than 2 months at the time. Again, kind of like persistent depressive disorder, but again, for bipolar. And they've never had a major depressive episode, manic episode, or hypomanic episode, ever. So again, it's that low level, not quite to the threshold of developing either disorder, but that those symptoms are still there, which can get in the way of overall functioning. And the prevalence, the lifetime prevalence, so the chances somebody might develop this over their entire lifetime is anywhere from 0.4 to 2.5%. Okay. I think this, yep, this is the last one we've got. We've got disruptive mood dysregulation disorder. And this is going to, geez, where did it go? These are going to include this is going to include severe temper outbursts occurring frequently against a backdrop of angry or irritable mood. So this is a diagnosis for kids. This is a diagnosis for kids, and well, the criteria. Okay, so they've never been diagnosed with a manic or hypomanic episode. Again, between the age of 6 and 18. I'm trying to find this so I have exactly. 78. Okay, I just missed it, I think. We did. Okay. So, and these mood outbursts, they're inconsistent with developmental level, because again, you might have some outbursts in like 7, 8-year-olds, but they're outside of what is quote unquote normal. And again, they average about 3 or more times a week. So these outbursts have to happen about 3 or more times a week. And the mood between temper outbursts is commonly irritable or angry most of the day, nearly every day. And again, parents, teachers, friends, they're all noticing this. And again, it's been present for 12 or more months. So these outbursts have to have lasted for at least the last year. And throughout that time, the child has not had a period lasting 3 or more consecutive months without all of those symptoms. So you're seeing these outbursts persistently, at least 3 or more times a week. And these outbursts and these symptoms, they're occurring in at least 2 of 3 settings. So at home, at school, or it has to be at home, at school, or with peers. So 2 out of the 3 of those. It can't just be at home, just can't be at school. You have to have that corroborating evidence at multiple locations. And the diagnosis really can't be made for the first time before 6 years of age or after 18. That's going to be a different diagnosis. And let's see here. Usually the age of onset is going to be before the age of 10 in general. Otherwise, you're probably looking at something else, but you'll see that diagnosis before 10, but it can go up to 18. Let's see here. If there's anything. Yeah, and part of the reason that this was developed was to combat the stigma associated with diagnosing kids with bipolar disorder, because even diagnosing an adult with bipolar disorder comes along with a lot of stigma, but to diagnose a child, you think about the stigma that's going to happen in school, amongst friends, in the community. And so as a result of that, they developed this. So it's kind of like bipolar for kids in a way. I hate to call it that, but it really kind of is. The prevalence rates, let's see here. There was a population-based cohort study of Brazilian 11-year-olds, and the prevalence rates were around 2.5%. Let's see here. Data suggests the diagnosis may be more common in younger age groups. So in a group of 6-year-olds in the United States, about 8.2% would have been diagnosed. Risk factors. So if that kind of gives you a little bit of an idea, and you're going to see this more in kids who are just like chronically irritable, disruptive family lives, abuse, neglect, trauma, death of a parent, parental grief, divorce, malnutrition. Those can be basis for the development of this disorder. And then also a family history of depression might be a risk factor as well. So hopefully that gives you a little bit of an idea of disruptive mood dysregulation disorder. And again, these were your bipolar mood disorders. Again, you're experiencing both the depressive related symptoms and the mania related symptoms in these disorders. So I hope you're doing well. I hope you have a great day. Please let me know if you have any questions, and we'll be talking to you soon.